So again, welcome everyone. We are excited to have you all with us. And today we'll be talking about another one of our 6 C's in our 6 C's framework. And we'll be talking about collecting and analyzing, translating relevant data. So for the people in the audience that are a little bit of data wonks like me, this is for you. So for those of you that are new to Trust for America's Health, we are an independent, nonpartisan public health and prevention-focused organization based in Washington, D.C. Our 3 main areas of focus are advancing evidence-based policy and advocacy with a focus on equity. And we're deeply committed to improving the health of everyone in the community. So we have a lifespan approach, and we are obviously focused on making disease prevention a national priority. TFAH also publishes several reports annually. We just released one on public health funding, and as you can see, we have several on ready or not related to emergency preparedness, and Pain in the Nation was released earlier. And we also have some reports that are specifically related to the Age-Friendly Public Health Systems Initiative. And this one is about our housing and identifying policy recommendations and challenges there. And also want to make sure that we acknowledge and recognize that this work is funded by our generous funders, the John A. Hartford Foundation. So just some logistics and housekeeping as you all get settled in for today, this afternoon, or some people, oh, it's still afternoon. Make sure you're completely muted during our session. There will be time to engage directly with our presenters. So we'll invite you to come off mute at that time, but during the actual presentations, we would like you to stay muted. If you have any questions during the presentation, feel free to put those in the chat. We will be monitoring the chat for questions. And if there are, again, questions for our presenters, we will share them with them at the end. Closed captioning is also available during our training. So if you go into more under your taskbar, I think that's where you can enable the captions for this training. So as I mentioned, this is another one of our C's in our 6 C framework. This is our 6 C framework that we have been presenting on for this entire year so far. So we've done creating and leading, connecting, convening, coordinating, and now we're focusing in on collecting, analyzing, and translating relevant data. As a little bit of admittedly a data wonk, and as I say that because I get a little excited about innovative ways to not only collect data, but innovative ways to use data. I'm excited to present this session introduce this session. And in the vein that we have worked with some great partners in the states that have produced their own data reports. So in Mississippi, they've produced their Healthy Aging Data Report. And it's a massive book of just data profiles across the state. We have in Washington State, another one of our subgrantees who created individual data profiles on different counties that highlight, again, the different needs and health of the different communities across the entire state. And in Florida has a very robust data dashboard that you're able to filter out by the county and the year. And also it includes a lot of variables that address disparities. So again, we know what we can do with this data, but we also, in that vein, wanted to talk about a lot of the data sources that not only these reports draw from, that we draw from as well. So we're excited to have 3 amazing speakers with us this afternoon. So our first speaker is Dr. Michelle Town. She's the branch chief under the Population Health and Surveillance Branch with the Centers for Disease Control and Prevention. And she'll be talking to us about the Behavioral Risk Factor and Surveillance System Survey. She'll get that right better than me. Dr. Kristen Robinson, who's a social scientist with the Administration for Community Living, who will be talking and sharing highlights from the Profile on Older Americans. And finally, Matthias Kirch, who is a statistician staff specialist at the Institute for Healthcare Policy and Innovation, and also a health informatics specialist at the Michigan Social Health Interventions to eliminate disparities. And he will be sharing information about the National Poll on Healthy Aging. So I will turn it over to Dr. Town, and I have your slides, Dr. Town, so whenever you're ready.
Hi, everyone. Good morning. Good afternoon. I'm sorry. I've been up all night. I've been on international meetings for the last 3 days. So bear with me today. Can you all hear me? Great. I am Dr. Michelle Town. I am as she said before, I'm the Chief of Population Health Surveillance Branch, and I'll just be giving you a brief overview of the Behavior Risk Factor Surveillance System. Some people call it BRFS, but we call it the BRFSS. Next slide, please. I'm not sure how many of you all know about the BRFSS, but the BRFSS is a state-based survey. It's not just one survey. We consider it to be 57 surveys. The BRFSS is collected in the all 50 states, DC, and it's in 6 U.S. territories. We mostly report on the 3 of the U.S. territories. The other 3 that we do point-in-time surveys. The survey is actually collected January through December each year. We collect data on adults 18 years or older. We collect data on health conditions and health risk behaviors, healthcare access and utilization, chronic health conditions, injuries, preventable infections, and a lot of other topics. So we've been collecting the BRFSS since 1984, and we still have that data that can be accessed, but it has to be, of course, pulled up. We have to request it if you ever want to go back that far. But we do, we've been collecting that data for since 1984. And each year we collect at least over 400,000 interviews. And we are considered to be the best source data for state and county level data. Next slide, please. The BRFSS, we consider to be a partnership. And each member that that work with the BRFSS data, they do provide funding for the data collection. The states are really responsible for the actual survey implementation. They work with us on the sampling, the questionnaire design, and actually they are the ones that do the data collection. Some of them are in-house data collection, some of them are through universities, and some of them are through major companies. The CDC PHSB area, which is my group, we actually do design the sampling. We get the information from what the states are looking for, and then we design the sample design. We actually provide them instruction on how to collect the data. We do all the data editing, cleaning, weighting, and we do data dissemination. And we do just a lot of TA to the state health department. We also have CDC programs. They are involved in the process where they propose questions on what they would like to see on the BRFSS. Those particular questions have to be approved by the state health department, well, the BRFSS coordinators. We have a process where they propose the questions and my group vet the questions. We do cognitive testing, and then after the data has been cognitive tested, we have a conference each year that we come in and we talk about the questions on the that's going to be on the upcoming year's survey. They talk about any changes, and they propose whether or not they want to add questions to the core, to the modules. And it's a conference that every coordinator should attend. And we do have the CDC programs, and we have persons from just all over that actually attend that conference. Next slide, please. I just kind of want to briefly talk about the BRFSS questionnaire. I know this is what you all were wanting to see. What do we have on there and what type of data that you all can use to look at older adults? Next slide, please. The BRFSS is actually made up of 4 components, but the main survey is the core survey that's implemented in every survey, every state in the US. Every state must have the exact same wording on all the questions, and it has to be implemented exactly the same. We have also the optional modules, and these are sets of questions on specific topics. They may have a lead-in question that's on the core, and then they may want some additional questions in the optional modules. And so the optional modules are selected by state. So if you think about the BRFSS, that's why we consider it to be 57 times 2 really surveys, because it is a telephone survey where we collect data on the landline and the cell phone. But when you look at the different optional modules, every state survey does not look the same. It looks the same for the core part of the survey, but the optional modules make it an individual survey. So the states do have a process where they meet with their constituents within the state health department to determine what modules they want to use each year. And then we have a state added section where these questions are developed within the state health department. They are not state questions that we vet. And so each state develop their own questions. They may not be in line with some of the other states. They may be collecting the same topics, but it's their own individual questions. And those state added questions are not on the main BRFSS. We also have projects that we sometimes collect that's outside of the BRFSS, but it's using, maybe we use it as maybe a callback or something that's if we need to collect some quick data. We're currently collecting the asthma callback survey. So that's of people who have responded on the survey that they actually have asthma, and we call them back to get additional information if they are an adult or if they have a child inside the household. Next slide, please. So this is a slide that just kind of shows you the different topics that we have on the BRFSS core. And so I highlighted some of the questions that I thought would be important to just highlight because these are some of the topics that when you're looking at older adults, and if you see BRFSS can be used for just about any age group. When you're looking at the height and weight variables, these are the demographic variables, of course, that describe the person, but also we calculate the obesity of the participant using the height and weight. I didn't highlight the disability, which I meant to, but because I did do it as a health topic on the other side, but it's still considered to be a demographic variable also. And if you look at all of the different topics, if you think about it, really any topic, but the ones I highlighted, I thought would be very important because when you're talking about cardiovascular diseases, I know sometimes as the person's age, they have more cardiovascular disease. And also when you're looking at healthcare access, is whether or not just that they have healthcare, but whether or not they have a primary doctor, whether or not they're going to the doctor, do they have problems getting to the doctor? So those questions can come into play also. And then I know even with healthy days, how do they feel, how many days of a week are they feeling healthy? So it's just different, emotional support, life satisfaction. A lot of these can come into play when you're thinking about health. And diabetes, of course, is very important. Sleep status, because I know as the person's age, sometimes they don't sleep as much as before. So these are some of the topics that I think that BRFSS can use for looking at the older adult populations. Next slide, please. And this is just, I just kind of wanted to show you what the structure of some of the questions look like. So when we're looking at chronic health conditions, we'll give them a prologue. Has your doctor, nurse, or other professional ever told you that you have one of the following? And it's yes or no answers or not sure. So we ask them about heart attacks, coronary heart disease, stroke, asthma, diabetes, skin cancer, and COPD, which is very important in the older adult population. And then also, have they been told about arthritis, rheumatoid arthritis, lupus, gout? So these are some of the questions that I think is very important for you all to look at. Next slide, please. Also, these are topics that so the topics I talked about earlier are the ones that were on every core, that's every year. Now these topics right here, they're on even or odd years. So even though they're on even or odd years, sometimes they can be also on the other, let's say if it's selected as an even year, on the odd years, they can be an optional module. So sometimes they're carried on throughout the entire process. It's just whether or not the CDC programs will pay for those optional modules to be added to the survey on the years that they're not on the main core part of the survey. So these are some other topics that I thought that was very important. And you all may differ, you may say, okay, all of them really, but I just thought these were some of the ones that I thought was very important that you may want to look at. Next slide, please. So I kind of just showed what some of the questions look like when you're looking at disability. We're asking about, are they deaf? Are you blind? Do you have any physical or mental or emotional conditions? Do you have difficulty walking or climbing stairs? Do you have difficulty dressing or bathing? And And, because of physical, mental, emotional condition, do you have difficulty doing errands or, shopping? So I think this is very important. Also, I think I had talked to Megan, I think it was Megan and Karan about, I know they said they had already talked to the FALLS group. We collect data, FALLS information on ages 45 and older. I know they're thinking about expanding that age group to even younger, because I know they were looking at whether or not FALLS are affecting the younger adults also. Next slide, please. I was thinking about maybe hypertension awareness, because I know these are some of the things that you want to keep up with. Everyone should do that, but also the older adult populations, to make sure that, to look at whether or not they've been told by a healthcare professional that they have hypertension, and are they taking prescription medication for high blood pressure? Are they aware of their cholesterol status? Have they been told that they have high cholesterol? Are they current taking medication? So I think this is some important information you all may want to look at also. Next slide, please. And these are the optional modules. And we have these are just some of the optional modules that we have. So the optional modules are on the survey if the programs pay for them to be on the survey for the year. So what we do is we gather funds, we contact each one of the CDC programs or one of the federal programs that actually sponsor the modules. And if they pay for the modules, then they're on for that year. So I think these are the ones I highlighted, I think are the ones that I thought was important that's currently on the 2021 survey. So when, as I said before, when you're looking at the adult asthma, there's additional questions. So it'll ask you, do you have asthma? So an optional module can get some additional information on asthma. And these, like anxiety and depression, we have measures that you can calculate anxiety, depression. Even though we do ask if you have arthritis, when you're looking at arthritis management, how are you managing your arthritis? Caregiving, just asking them if you're a caregiver of someone in the household. And so it's just a lot of information I do believe that you all can get from some of the optional modules. But you have to keep in mind the optional modules are not asked of every state. Sometimes it's asked of 20 states. Sometimes it could be asked of, very few states. So it just depends on what the state is looking for from year to year. And sometimes with the optional modules, the states may not want to collect the entire optional module. They may want to choose a question. So if they only choose a question out of the optional module to collect that year, then they have to put it in the state added question. Next slide, please. So I just kind of wanted to show you what one of the optional modules look like. We're currently, we developed the social determinants of health module, and it's based on a CMMI social needs assessment. And so the topics that are covered in this particular module is 10 questions. And we talk about food insecurity, housing insecurity, transportation, whether or not they were able to get to the doctor, and social support, well-being, employment, economic stability. So I'm sure now the economic stability, of course, probably not come into play with the older population, but when you talk about food insecurity or housing, or even transportation, social support, I think these are really important. So in 2022, it's the first year that we implemented the new module. And so we currently we had 42 states that collected the module. We are currently have quite a few papers that we're going to be writing coming up. So we have a MMWR, I think, that we're going to try to have out in November, that'll give information on this, this particular module. And then we're also going to have quite a few articles coming out soon after. Next slide, please. And tell me if I'm going too long so I can stop. I just had a little bit of information on data collection and use, and then I'll be finished. Next slide, please. Do I need to let me know? And as I said before, this just shows what our actual methodology is. We have a landline and cell phone RDD survey, and we do ask questions to screen persons out because we only collect data for persons 18 years or older who live in a residence or either college housing. And sometimes we send out a postcard asking, well, just notifying them that they will get a phone call regarding the survey. Next slide, please. And these are some, we use the BRFS data for reporting timely health statistics for the public. We monitor risk factors for chronic diseases and premature death. Some of the states use it for informing legislation and health policies, and also some of the CDC programs. We use it for evaluation of public health interventions and policies, and just responding to public health emergencies. Next slide, please. And this is just where you can find the data. This is our BRFS webpage. So we have things that'll talk about the BRFS, but this particular page, it talks about the prevalence, is the prevalence table. And so the prevalence tables is all the data's in the course part of the survey. You can pull, this goes by question. You can get information by state for all of the core variables that's in the survey. And we also have a web-enabled analysis tool where you can run some additional analysis that's not necessarily in the prevalence tables. You can do some cross tabulations and some logistic regressions using that particular tool. We also have interactive maps, and we also have city and metropolitan statistical area data on our website. And I think that's all I put in the presentation. Next slide, please. Yes, thank you so much.
Thank you so much, Dr. Town. I actually learned something new about that on that last slide. So thank you very much. We're going to move on to our next presenter, Dr. Robinson.
Hello, thank you for inviting me here. I'm here to talk about kind of a funny little report called Profile of Older Americans. It's produced by the Administration for Community Living, yet we're not a statistical agency. And so the way we put it together is that I feel a bit like a scavenger. I've taken data from my co-presenters and I've put it into the report, but it's great data. So primarily, we use data from the Census Bureau, National Center for Health Statistics, Bureau of Labor Statistics. And I think my main goal today is to talk about the data sources. It's primarily a national report, but I'll highlight where the data can be looked at lower levels of geography, because I know that's of interest to this group. Next slide, please. This is what it looks like. It used to be just a Word document. And over the years, I went back to our website to see, we have it starting in 2005. And over the years, it's kind of become more popular. And so our communications folks decided to make it look a little nicer. And so at the end of this presentation, I have the URLs so you could see where to access it on the acl.gov website. It's primarily an annual report. I'm kind of scared to say we didn't do it this year for 2022 for a variety of reasons. We were considering making it an every other year report. I don't know. I've had a lot of pushback. So we may be bringing it back to an annual report. We're definitely doing one in 2020. For 2023, it'll come out in 2024. Next slide, please. These are the topic areas. I was flipping through it, and they usually stay the same: population, demographics, employment, income and poverty, housing, health, healthcare, and health insurance, family caregivers. And in the last 3 years, we've had rotating special topics. One was on emergency preparedness, one was on COVID, and family caregivers. We had a bigger one on family caregivers, which I did use BRFSS question for. The indicators or the variables within each of these topic areas changes a little bit over the years. If the surveys that we're accessing changes, it's only on the 65 and over population. So if for whatever reason, if the Census Bureau or NCHS decides, hey, we need to merge a couple of years of data because there's a risk of disclosure or there's something else is going on, it changes in here. So it's not like you could say that we can do a trend analysis that every year the same variables are coming up, but it's mostly the same. Next slide, please. So this is an example. I love the Census Bureau and I rely heavily on their data. And this is, I think, our first chart in the profile. And basically it uses population estimates for 1900 to 2020, and then projections. Population estimates are what the Census Bureau does between decennial censuses. So between 2010 and 2020, each year they would take the fertility, mortality, migration changes and apply it to the previous decennial numbers, and they go all the way up to the next decennial census and they start again. So the numbers are more reliable in the beginning. As you get to 2019, you know, it gets a little bit, you know, you're kind of relying on models, but the projections are only done every couple of years. So these are from 2017. They don't change often. When they do, it's kind of a big deal. So if you download them once, you don't have to download them again for a while. That's, I think, the best thing to say about them, because it's kind of a big, it's a big data file that can be hard to manage and to figure out, because it's by race, by age, by sex. It's a lot of numbers. And basically that's the other thing. Population estimates, their basic numbers are kind of your denominator data. So it's age, sex, and race. You can get the national, state, and county level. So that's good for people who need to know kind of counts in their local levels that they're working in. You can go in and get some estimates for how many people are living in the area. Next slide, please. This is a map. Like maps are fun. It basically shows the change between 2010 and 2020, the percentage of older population in each state. And for each report, we change it for the 2011 to 2021 and so on. And this one shows Alaska, I think I wrote it down, 73% increase in the population 65 and over the past 10 years. That's a pretty big change. And then the other states with the polka dots, those are the ones at the next highest level. And I think we know this is happening across the country, where the states are, the older population is growing, and it's important to know. And again, it's the population estimates that can give us this information. Next slide, please. So this is a different survey from the Census Bureau. It's the current population survey. This is the survey where they talk about employment numbers coming out. And it's always big in the news, hey, the new employment numbers are out. And actually, I've been at the Bureau of Labor Statistics. They lock down all the doors. There's tape around them. No one can come in and out without an ID, because the numbers are so important to the economy. But maybe a little known fact is that there's a March supplement called the Annual Social and Economic Supplement that provides demographic data. And so we're able to get things like living arrangements for the 65 and over, and other ages, of course. But these are kind of nice estimates, because it's another way that you can rely on the Census Bureau data, which is pretty good. And you can find out more things about, some social demographic, social characteristics besides just the labor force. And so I picked this slide because it shows, living alone is a risk factor often for older adults. And you see a third of older women and like a fifth of older men are living alone. And that's, it's important to know. And it's for the Administration for Community Living, it's one of our areas that we target, because we realize that people live alone. They may not have the resources they need to remain living in the community safely. So this is an important one for us too. Next slide, please. Poverty, same data source. So CPS is known for income and poverty, health insurance, and employment. Those are the big areas. But this is that supplement I was telling you about again. And I think what I didn't include, because these are taken right out of the report, so I didn't recreate them. I just took them out of the report. But what's interesting here is that, I think I wrote it down somewhere, the older Hispanic women living alone have the highest poverty rate, and it's about 37%, I think. So it's just important to kind of dig a little into the details to see, it's important to know poverty rates, but when you kind of get down and you dig a little, it's like, wow, that's a lot of people living below the poverty level who, maybe what you're doing, you can reach them. What we're doing at ACL, it's good for us to know too. So that's why I included this one. Next slide, please. Okay, now we move over to health data. You just heard about the AFPHS, which is a great data source. I primarily go to the National Center for Health Statistics, and for this report, I use the National Health Interview Survey. That survey has been around since the 1950s, and it's really got some great data in it. It's one of those data sources that I usually go to, although it's changed a lot, and that's one of the things that the way they report the data has changed. Their survey, because of over time non-response rates, they're important, and if fewer people are responding to the survey, the estimates get a little wonky. So they've reduced the survey and shortened it to try to increase response rates. So they're not asking as many questions as they used to. And, you know, that affects a lot of things, but they've had to make cuts, and it's understandable. For ACL, one of the big cuts they made was age at disability, and that's important for developmental disabilities. It's important to know when the disability started. So they have a program where agencies can buy, kind of like the BRFSS, they can buy a supplement and they can add questions. And so that's what we did, except COVID happened. And so, you know, the response rates during COVID kind of tanked. So anyway, we're trying to work our way through it and make the best of what we can. I think it's true for every data source. You know, I work on another data source called the National Survey of Older American Act Participants. So it's only people who receive Meals on Wheels, congregate meals, transportation. So it's not national. It's nationally representative of our clients, but not for the nation. And we didn't do it because of COVID. We didn't think we could go in and put more burden on the area agencies on aging that we rely on to get the client lists. So, you know, we missed a year, but we did think it was the right decision at the time. So this is, at the end, you'll see the URL for this website. And I just did screenshots to show you. Right now, the best data, the way to get the data is to go through this interactive data query systems. It's the most recent data. You can see they have 2022, 2019 to 2021. And it gives you, the next screenshot will show you, but it's just, I think it's one of their best ways they've come up with so far to get access to these data. It's more straightforward. You can get the older data, but it's a little tricky. They have a report called Health US you could go to. They have a lot of Excel tables that are associated with that report. And they have some other ways that just aren't as easy. So this is the one that I relied on for the profile. Next slide, please. So this is just a screenshot of the system. And what I did for the select topic, I picked disability, and they have all different types of health variables there. Trends over time. So I had 2019, 20, and 21. And then I always am looking for 65 and over. So often I can find the indicator I'm interested in, but they don't have it by age. So this is a nice way, and you can group it by race, you can group it by socioeconomic status, by disability. They have a whole bunch of things you can choose from, you know, for whatever your interest is and whatever you would like to find out more information about. And what I really like about this system is that the notes are very detailed. And if you have worked with disability data before, disability is hard to define. People define it different ways. And it's important when you're reporting data to show or to add in, at least in a footnote, what it means. How are they defining disability? Because you could look at two different data sources and get completely different numbers because of the way they ask the questions. You know, it's just different. And I don't think anyone's come up with an answer that everyone loves. The government came up with 6 questions that they required all different surveys to have in it, 6 disability questions. Yeah, not everybody loved those questions. It was like a compromise where everybody didn't like it. So that's how they won. You know, basically no one was happy. But and if we go to the next slide, I'll show you what it is. This is actually, oh, I'm sorry, we're going to get to it. These are some of the variables that I got from that system. So it just shows that, and I think this is a funny one. 65 to 74 and 75 and over. Some of the surveys have switched to only showing 75 and over and not 65 and over. So we've had to make some adjustments in the way we reported in this report. And then we just have arthritis. And again, it's the way the questions asked that you have to keep in mind. Diagnosed diabetes, that last bullet on there, is different than do you have diabetes? Because it's different. If you have it, some people might say they think they have it, or other people might say, you know, I've been diagnosed by my doctor. A medical professional has told me I have diabetes. So it's just little things like that to keep in mind when you're doing research and looking at different data sources to choose for your projects. Next slide, please. Oh, this is just a continuation. And the one thing I wanted to show here was that for the National Health Interview Survey, they released preliminary results. So that's why it says in 2021, January to June, because I wanted to be specific to show these are preliminary. It wasn't a whole year worth of data. These were the first 6 months of the year. They released them, but they're also saying, hey, you might want to check back when we get our full year out just to see if it's changed. It's just another thing that's important to know. And then, okay, next slide, please. Oh, here's the disability one. So since there was such, I don't know, discussion about whether or not those 6 questions were the best to add to the federal surveys, there's a group called the Washington Group that came up with another measure. And this is the one that NCHS is using. It adds communication difficulty, that last one there. And that's important. People with a communication difficulty, you know, they have different needs. They have different healthcare concerns, different ways of, you know, communicating with doctors, perhaps. So this measure, I think, is the one that they're trying to move everybody over to. But as you see in the note, and I also see a typo, there's two sources. Any disability includes those reported who have a lot of difficulty or cannot do it at all in any functioning domain. So it's just one of those nuances that, you know, that's a little different than the way other disability questions are asked. And it's something you just want to know. Next slide, please. Okay, this is the last chart. This is an interesting one, and I don't know how many people have heard of this. It's the Household Pulse Survey. That's a joint survey primarily run by the Census Bureau, but at least 15 other federal agencies were involved during COVID. They needed a rapid turnaround way to find out what was going on and how people were feeling. And so this survey was maybe done 3 months in the field, 3 months, and then turned around and reported back on the census website immediately, almost as quickly as it could be with the government. And the interesting thing here is that it's a lot, I know it's busy, I'm sorry, there's a lot going on, but the general idea is that this was in our COVID, I guess it was our COVID special topic. So 2 years ago. And I don't know what we thought beforehand, but it shows that older adults were less stressed than younger adults during COVID. The top line, the darker blue, is 18 to 29. The bottom lines are the 70 to 79 and 80 and over. We learned in the other survey I mentioned that I work on for Older American Act clients, caregivers were the most stressed. They were the most stressed during COVID because they couldn't do what they needed to do for their loved ones. They couldn't get to them. They didn't have the same resources. I don't know if that's what's going on here, but this was just an interesting one, I think, to include. Again, another data source, it's still around, it's still happening, but it's just the government kind of turning around and saying, okay, we're not doing this right. We need to band together and let's get the information out to the people who need it, who could, you know, improve the lives of everybody, not just older adults. Next slide, please. Okay, these are just the resources. I put the profiles URL. The Census Bureau, I don't know if you're familiar with them. They have their traditional website, census.gov, but they've been transitioning over the past few years to this new one, data.census.gov. They haven't merged all their data sources over there yet. So some are there, some are still on the other one. You just have to figure out which is what you need. And then the NCHS, that's the one for the National Health Interview Survey. And that's it. I think I just have a thank you slide coming up. Yeah, thank you.
Thank you so much, Dr. Robinson. Again, things I didn't know, things I didn't know before today. And our final speaker, but certainly just as exciting as our previous speakers, is Matthias Kirch with the National Poll on Healthy Aging.
Thank you. Yeah, so I am here. I am the data lead for the National Poll on Healthy Aging. We are a very new data source compared to some of the other ones that you've heard about today. We started in 2017. This is a project that lives at the University of Michigan and is directed by the Institute for Healthcare Policy and Innovation. And it's sponsored by AARP and Michigan Medicine, which is our medical center at University of Michigan. Next slide, please. So the NPHA has 3 main goals, which was to develop a recurring survey of adults who are ages 50 to 80. And we chose that age range because they're people who are approaching retirement age and approaching times in their life where, you know, they might start thinking about aging and up to 80. And then disseminate these results through multiple channels. So we'll talk a little bit more about that. And our poll is really designed to reach multiple types of audiences. So not only to researchers and to people working in healthcare, but also to the adults themselves and to their families and caregivers. And so we do that in multiple ways. Next slide, please. We have used 2 different vendors to do our survey over the last 6 years. The first was Ipsos. They have a knowledge panel, and then we're currently using NORC's AmeriSpeak panel. Both of these panels are address-based panels, so they pull a random sample of addresses within the US of community dwelling folks. So we don't have anyone in nursing homes, for instance. And then they invite people to be part of their panel to conduct surveys multiple times during the year. So we field our survey twice a year with about 2,000 people ages 50 to 80. We have about 1,000 in the younger age range, 50 to 65, and 1,000 or to 64, and then 65 to 80, another 1,000. And so all of our results can be weighted back to the US population. We have in our data sets, you can break it down by region of the country. The smallest demographic area is state, but with a sample of 2,000, we don't have a lot of people per state. So those estimates are going to have quite big, margins of error. One of the nice things about a panel is that they take care of kind of recruiting the people to participate. We get 60 to 70% completion rate among these people who take our surveys, even through the pandemic. And for the Ipsos Knowledge Panel, all of the surveys were completed on internet devices. With NORC, we have about, I'd say a little under 10% who complete them by phone. Next slide. All right, so our poll topics are developed in cooperation with a number of faculty at the University of Michigan who are members of the Institute for Healthcare Policy and Innovation. We have faculty who come from a variety of backgrounds. So, there are many people who are MDs who actually see patients in the clinic and also do research. We also work with, people who are public health based, really varied backgrounds. Next slide. So I was going to give some examples of the kind of things that we found. So one of the really unique things we did was we helped validate a scale to look at everyday ageism that people experience. So this is not things like getting fired from a job, but things like, hearing someone make a comment about, getting older, somehow you're worse off. So we actually found that 82% of adults experienced one or more forms of everyday ageism. These are the kind of topics that can be really unique, and we don't necessarily do them over and over again, but we have them at a point in time. So next slide. Another one that we have actually looked at multiple times was looking at people's feelings of isolation. So we actually asked this question first in October of 2018, and we found what we thought was concerning: about a quarter of older adults feeling some level of isolation from others. This is when we decided to repeat after we, all started experiencing the pandemic, and the number went up to like twice as much feelings of isolation among this population. And we found since then, we've continued to ask this question each time, and we're still not back to the kind of baseline. So there's still quite a bit of feelings of isolation among older adults in our country. It's interesting to be able to look at some of these trends over time. Next slide. Some of our topics are kind of more traditional healthcare topics. This was looking at dental care, looking at how often people went to the dentist and for what reasons. Next slide. We also have asked about things like food insecurity and how that relates to people's health. And in our sample, we found that about 14%, of the population of adults this age are experiencing food insecurity. That was in 2019. Next slide. One of our other modules that we did a while ago was looking at how prepared people were for emergencies. We worked with a collaborator who does a lot of emergency preparedness with multiple states across the country, and ask questions about, do you have a supply of medications ready? Do you have food and water put aside? Are you signed up for emergency alerts in your community? Or have you talked to friends and family about what you would do in the case that you had to evacuate your home? Next slide. And another topic was looking at alcohol use among older adults. You know, we found about 2/3 of adults reported drinking alcohol, and you know, of those, more than a quarter had reported having 6 or more drinks on at least one occasion in the time period that we were asking about. So, you know, just really thinking about like how that relates to adults' health and wellness. Next slide. So one of our goals as the poll is to make all of our data available to the public. And we do this in a couple of ways. So next slide. Within the first 6 months of any screen or any of our polls that we do, we try to put out a report about all the topics included in the poll. So each survey that we do contains about 4 to 5 topic areas. And then over the course of the next 6 months, we work with our collaborators. We write a report that examines that in detail. So we might look at, you know, for instance here, experiences with patient portals among older adults. We'll look at it by age group, by gender, by race and ethnicity, by other health outcomes, things like that, and give a really in-depth report with suggestions for policymakers, for providers, and for patients themselves. And these reports can all be downloaded on our website. They will include, you know, some statistics, some graphs, some infographics, things like that. Next slide. Yep, and these are what the reports look like. So you can get a sense that, you know, you can see some different data points. There'll be a little bit of discussion about, you know, why this topic area is important, why we're asking about the question now, and what we found. Next slide. The second way that we're making data available is through the NACDA, the National Archive of Computerized Data on Aging. NACDA contains a lot of data sets related to aging, and ours is one of them. Next slide. So our goal is to get all of our data, the raw data itself, put up within 18 months to 2 years after we have done the survey itself. And what we put up here is our full data file. So you can see, and this is you know, very data heavy. So this is for the folks who really want to like download some data and play with it. But we have multiple ways of connecting the data, and then we also have information about it. So next slide. So these are the supplementary materials. We'll have the survey instrument available that will go into all the questions that we've asked, and we certainly welcome people to download these and, you know, use questions if they're working with community populations and would like to compare their results to what we found. We also have a survey report for each one, which is kind of the details about how this report was conducted and just things from our survey vendor around that. And then we have a code book, which shows the number of responses to each question and the type of data that you would be getting. Next slide. So the data themselves are all, you know, in a file that needs to be analyzed. So this does need like a survey kind of program to use. So SAS, SPSS, Data, RR will all work. And I'm sure that there's others as well. And the reason for this is because all of the data contain weights to make them relate to the full population. Next slide. I give an example here of this is in Stata. You know, you would have to apply a survey weight in order to look at the data. We don't currently have any sort of online version where you can do this, but as long as you have a stats person with you, you can download these data and use them. So next slide. How has our data been used? So in addition to our reports, which we have about, I think 54 of them out right now, we also have about, I don't know, 20 to 30 academic publications using this data as well. And our data have been quoted in a variety of news and other media sources. So we really try to put out data that's interesting and relevant and kind of newsworthy and get people talking about things. In addition to these, it's also, we've had our data quoted in some congressional hearings and also used by students to, to work on their both master's and PhD programs. Next slide. All right, so thank you. Our data are all available for use at healthyagingpoll.org. And then the next slide will give you our contact information if you have any further questions.
Wow, thank you, Matthias and Kristen and Michelle. I have learned so much today. I'm kind of blown away by all this. It's going to take me a little while to process everything, but this has been so helpful and very valuable. Really appreciate it. So Karan, you want to take down the slide deck for now, and we'll field a few questions. We don't have a ton of time, but there was one question that came through the chat. Michelle, this is for you. So is there any consideration to making the cognitive decline in caregiving modules as core modules? And if not, what is that process for adding to the core modules? Or would one module have to come off before another module got added? How does that work?
So actually, we embarked on the, I guess about 4 or 5 years ago, we went through and we looked at the core to see how many questions we had on the core and can we reduce the core, because it is a lot of questions. And so the process for actually adding modules, and just like you say, do we need to take things off? And we would prefer, if we do add something major, a major module on to the core, that we would take some things off, because we try to make sure that the data collection does not burden the respondent. So what we normally do, I think I mentioned it with the process is sort of like an 18-month process. So we send out an email to all the CDC programs and to the federal agencies to see if it's anything they want to modify on their questions. Do they want to add any additional questions, or try to lobby to be on the core? So they send us their proposals, we review the proposals, and if any major changes, we send it to cognitive testing. And then once we do that, we have a conference, usually it's in March or April of each year, and then the programs come in and they do a presentation on the use of the data if it's added to the core, or the use of the data if they're changing it. So then the states go back and vote, and it has to be 80%. Yes, the voting has to be 80% in order to be added to the core, and to be added just as a module is 75%. So we do have to be, it's voted on by the state health departments.
Okay. So with regard to the cognitive decline and caregiving modules, has anyone proposed that those be added as core?
I think they've proposed it in the past. I think we allowed it 1 year. I can't remember. We have so many that we've allowed, like for purposes of, I think they had something that they were working on with one of the NOFOs within the Healthy Aging group. I can't remember which, it might have been cognitive decline, but we did add it to the core for a year.
Okay.
But
Thank you.
That was only for like a special reason, and we still had to get it approved in order to do that. But I don't know. They can, of course, again, when we get ready to, each year they can also ask, can it be part of the actual core, but the states have to actually vote on it, so.
Right, interesting process. So this is, thank you for that, that response. For Dr. Town and for Matthias, I don't know what this means, I'm sure you do. Are there FIPS codes available for the data?
FIPS codes? That's the county codes. We do have county codes that we collect, but we do not release those codes to the general public.
Okay.
We use it for data processing to make sure we're putting people in the right counties when we're doing the for the weighting purposes. Yeah.
And Matthias?
And similarly, we don't have FIPS codes on ours either, just the state is the smallest level.
Mm-hmm. Okay. Understood. Thank you. Any other questions?
But we do now, you can get county information, but it has to go through the research data center. So we do have people putting in proposals in order to use the county indicator. And of course, I did talk about the MMSAs that we do have a data set for. which is usually like the metropolitan statistical or combined statistical areas.
Great, thank you. I do have a question for Matthias. So for the different reports, who decides on the topics for those reports, and can someone from the public suggest a topic for a report?
Yeah, absolutely. So our topics are all kind of crowdsourced. When you see our slides on the last page, there's the email address there. If you have a topic that you would like to see that you don't see reflected in ours, we would love to hear from you. We're always looking for new ideas about topics to include.
That's great. Thank you for that. Really appreciate it. Well, sorry, Kristen, we didn't have any questions for you today. I think that we really appreciated some of those charts, and especially that map that I think is going to end up being really very, very helpful. So we're going to wrap up now. And
I just want to say one thing. I'm so sorry.
Oh, no, go ahead.
When you said FIPS, it actually went straight to zip code. That's what people are asking. Yes, the FIPS codes are what you can get from the Research Data Center. Sorry. Yeah.
Okay, great. Thank you. Appreciate the clarification.
Yeah. Thank you.
Yeah, so we're gonna wrap up, and I know that Karan has a couple more slides that she would like to share, but thank you all so much. Thank you to our speakers for providing just some invaluable information for us. I know it's given us at TFAH some ideas, and I know that folks who are participating and watching and listening today, as well as those who will view this recording, this will also give them a lot of great ideas for how to kind of move forward with their data collection and different ideas for creating data reports. So really appreciate that. Karan, I will turn back to you.
Thank you, Megan. Just to wrap up, again, thank you all for attending. Again, I learned a lot, and if the Healthy Aging poll was around in the earlier days, I would have used it for my dissertation. But so our July training will occur on July 20th at 3 p.m. Eastern Standard Time. We will again be focusing in on another C from our 6 C's framework. And this is strictly for people that are viewing the recording of this training. If you would like, please pause the recording now and either navigate to the website listed, or you can scan the QR code to record that you have viewed this training. Again, this is strictly for people that have attended the training or viewing the training after we have recorded it. And thank you all for attending today.